are you? My name is Nicole Seti. I am a part of the Bachelor's of Nursing program. I'm currently in a class right now with Dr. Cloud. This is a part of my community population-based course. I currently work at an endocrinology office, specializing in diabetes. That's about 60% of our patients. I work with them every day, so it was a venture getting to know more about diabetes through renowned doctors and working with patients side by side, getting them through their diabetes, helping manage them. I wanted to put a little bit more emphasis on pre-diabetes, people at risk for diabetes, try and get a grasp on the problem before it becomes a problem. So this presentation is going to represent a little bit of that information. I also have a guest speaker. Her name is Jenny Wilkins. She is a registered dietitian specializing in diabetes. She works with the Medtronic company, which is an insulin pump manufacturer. So she's very knowledgeable on the topic as well. And she's willing to take any Q&A at the end or any questions that you have. So we'll get started. So first, some statistics about diabetes. In 2012, there's 29.1 million Americans that had diabetes. 86 million Americans that were 20 years or older had pre-diabetes. This was diagnosed and undiagnosed. So you can have pre-diabetes and not even feel symptomatic. This is the 7th leading cause of death in the U.S. And along with diabetes comes multiple other health problems. It's a piling effect. Once one goes south in the body system, it affects other things in the body system. Diabetes is a big contributor to those. So complications, comorbidities, low blood sugars, high blood pressure, high cholesterol, heart attack, stroke, blindness, kidney disease, nerve damage, also called neuropathy, and amputations, unfortunately, can be a result of diabetes. So you're going to want to know what puts you at risk for diabetes so that you can start to become more aware of what's going on with your body. The single best predictor for type 2 is obesity and being overweight. Type 1 is more of a genetic predisposition to diabetes. So we're focusing more on type 2 because it's more of the preventable type of diabetes. A BMI of 25 to 29.9 is considered overweight. A BMI of 30 or higher is considered to be obese, and 1 out of 4 Americans is clinically obese. And the BMI is determined by your height and your weight. So that's how you get that number. Prediabetes, also called glucose intolerance. It's a higher than normal glucose, but it's below the number needed to be diagnosed with diabetes. And this number that we're speaking of is the blood glucose. A normal blood sugar is between 60 and 100. That's a healthy, normal person's blood sugar. If you're between 100 and 125, fasting, meaning no food or drink in the morning before you take your blood sugar, this is going to be glucose intolerance or pre-diabetes. Diabetes will be diagnosed once you're over 126. A random plasma glucose test, meaning you can take this blood test at any time of the day after eating, it doesn't matter. If it's over 200, then that's also a way to diagnose diabetes. If it's over 126, fasting, that's a way of diagnosing diabetes. So this just puts a nice little chart up about fasting blood glucoses, what normal, pre-diabetic, and diabetic numbers look like. Hemoglobin A1C is a 3-month average of what your blood sugars are. This test can be done fasting, not fasting, it doesn't matter because it's a 3-month average. Less than 5.7 is the normal person's A1C. Prediabetes is between 5.7 and 6.4, and then a diabetic is 6.5% or higher. So other things that put you at risk for diabetes could be your ethnic background. Hispanic Americans, African Americans, Native Americans, Asian Americans, Pacific Islanders, Alaskan Natives, all those are at higher risk for diabetes. It's just a predisposition that these people, unfortunately, are at risk for. High blood pressure, typically around 140 over 90 or higher. That can put you at risk. That's when cholesterol plays a role. That could be causing high blood pressure. A low HDL, which is the good cholesterol, and a high triglyceride level are two warning signs. For women that were pregnant and had gestational diabetes during that time, that puts you at a higher risk for diabetes afterwards down the road. A sedentary lifestyle, exercising less than 3 times per week, that puts you at risk, and it's really, for exercising 3 times per week, I found that that's really pretty moderate to high level physical activity. Low to moderate should be 5 days a week that you should be exercising. Family history, if you have a parent or a sibling, so immediate family, that puts you at higher risk. Also, polycystic ovarian syndrome will put you at risk. And then your age, of course, anybody can be diagnosed at any time. However, if you're over 45 and you have any of the risk factors, you're at higher risk for diabetes. So there's a diabetic assessment test, and that's one of the papers I handed out to you. You can answer these questions. It tells you how to score yourself. There's a BMI chart to the right that can tell your BMI, and then you add up the points at the end, and that score will tell you what your personal risk is for type 2 diabetes. So there's questions such as, do you have a mother, father, sister, or brother with diabetes? Another question is, have you ever been diagnosed with high blood pressure? Your age, how old are you? Man or woman, and then if you're a woman, the question also follows, have you ever been diagnosed with gestational diabetes? What's your race or ethnicity that best describes you? Are you physically active? And then how tall you are, and then your weight. So that determines your BMI. So you're welcome to take this risk assessment now, or you can take it at the end at your own convenience, just to give you a little bit better idea of what your personal risk is. Ways to prevent diabetes. If you have prediabetes, it does not mean you're going to get diabetes. Early treatment can reverse the blood sugars into a healthy range, and you may never be diagnosed with type 2. You can lower your risk pretty significantly. It says 58% with only a few interventions, by losing 7% of your body weight and also exercising moderately at least 5 days a week for 30 minutes a day. And I listed some examples of what that kind of exercise could be. So that's a pretty big impact on lowering risk for such a horrible disease with such an easy prevention. Lowering your weight not only reduces the risk for diabetes, but it will also help with reducing the risk of heart disease and stroke, lowers your blood pressure, and lowers your cholesterol. Just some tips to help get you started. Cut back on calories and fat, be physically active, eat a healthy breakfast every day. Not eating is not the answer. Also, avoiding carbs 100% is not the answer as well. That's your body's fuel. Your body needs carbs. The key is moderation and portion control. If it helps, keep a record of your weight, diet, and activity, just to track your progress. A little bit on nutrition. This is Harvard's plate, their version of the plate guide. You might be more familiar with the government's, the typical myplate.gov. This one is a little bit more interesting. Not to start any controversy, but there are, some indicators saying that the myplate.gov could be a little bit more swayed in a certain direction due to the influence that farmers and agriculture has on the whole government. So they're saying that their plate is non-biased. It's strictly based on facts, and you'll notice the little difference here. Their vegetable size is much larger. Milk was replaced with water. So that's some interesting information if you want to compare the two. Also, another good resource for your diet is the dietary guidelines. There's a 2010 version out right now. The new one's coming out in 2015. It's an abundance of information regarding what foods are good for you, what foods are bad for you, portions. It breaks everything down for you. So it's just a really good resource to check out on your own if you wish, to get a little bit more information about diet. I just wanted to go over going over labels. There's portion control. So easy way is your fist is about 1 cup, your palm is about 3 ounces, your thumb is about 1 tablespoon. So when it comes to things like using butter, your pat of your thumb. And then the nutrition guide here, you want to limit the ones in orange. Those are the ones to make sure that you're not going overboard and get enough of the vitamins down below. What I thought was interesting that I didn't really realize before was the daily value. If the number's lower than 5%, that food has a low source of whatever that is, so the vitamin or the nutrient. And if it's above 20%, then it's high, it's rich in that resource. One of the doctors I work for put out an article in Style magazine recently, which was really nice, and I asked if I could use some of her material. So she says in that material, to eliminate sugary drinks such as soda, juice, and sweet tea, you'd be surprised how much those 3 things will impact your diet and how much sugar you get in your diet just through those things. Watch your intake of high sugar foods, baked goods and candies. And then also, again, don't eliminate carbs, but portion control is key. I went through the American Diabetes Association website. It's very helpful as well. They offer so much information. I grabbed some of the nutrition information off of their site that just briefly describes some foods to give you an idea of what to eat, what to go for when you're hungry, when you want that little snack. So it's very helpful in that. I always have problems figuring out what I'm going to eat for dinner. I can never make my mind up. So I thought it would be cool to be able to go in here and pick something out of the starches and something out of the meats and something out of the vegetables and help you in that sense. So I'm going to leave it off to Jenny now.
But my name is Jenny Wilkins. I am a registered licensed dietitian. I am also a certified diabetes educator, and I have received my bachelor's and master's degree from Eastern Illinois University up in Illinois. Is anyone familiar? Go Panthers, thank you.
U of I.
U of I, okay, my neighbor. I took biochem there. Hard, it was hard, but enjoyed my time. Just to give you a little bit of background on my work history, we moved to Florida in 1995, and when we first moved to the area, my husband at the time was an exercise physiologist. He is no longer, but he was at the time, and I looked around for a job, a part-time job, something in the dietitian world. And what I found was nothing, but there was one opening, and it was in a diabetes center. And I swore to myself that I would never do diabetes. I absolutely hated it. Didn't like it, didn't want to deal with it. And 1995 was the only job, part-time, had a job share with another mom, that I took that job. And I'll tell you what, ever since then, I would never look back. 5 years in that diabetes center teaching in and outpatient classes. From there, after our 3 kids were born, then I worked at the other hospital in town teaching in and outpatient classes, decided that it was time to go back into the workforce, and worked at contracted with a lot of different places. Did speaking for Merck, speaking for Sanofi, and became a real estate agent. I don't know why, just in my spare time. Then we had our 4th child, and in between all of that, I said to myself, I'm ready to stop contracting, and I want to do something. You know, I was always in diabetes. I always had my legs in it, but now I really want to get more serious. So for the last 3 years, I've been working for a company called Medtronic. That is insulin pumps, where I work, gosh, I wish I could say 40 hours a week. It's probably 60 to 80. Very intense, absolutely rewarding, wouldn't trade it for the world. But I absolutely cannot wait to share with you the experiences of 19 years and a huge passion for diabetes and what that's looked like. So some of these slides that I put together, I will quote you from where they're at, but I'm such a person that likes to simplify information. So I always called myself the professor of dumbing it down. I hope I don't offend anybody by saying that. But I love going to these seminars and taking all that technical medical information and translating it to patients so to really put some skin so they understand the disease process and what they're doing. So Nicole laid out a great explanation of prediabetes and risk prevention. This is going to be more specific into what diabetes is. So the technical definition is what you see on the board in front of you. This is from the JDRF website. Diabetes is a group of metabolic diseases where the body's pancreas does not produce enough insulin or does not properly respond to insulin produced, resulting in high blood sugar levels over a prolonged period. There are several different types of diabetes, but the most common forms are type 1 and type 2. Both impact glucose levels, and if left untreated, can cause many complications. Very comprehensive definition, very true. And in all of that, that leads us to the breakdown of the different types. And again, I just like to kind of lay that foundation out there because there's a lot of misconception about what these types are. Type 1 is a smaller percentage of the population, about 5 to 10% are diagnosed with type 1. And this is an absolute deficiency of insulin secretion. What's interesting to note is before 1921, there was no insulin. They didn't have any insulin to give patients. So when you were diagnosed with type 1, your life expectancy was 3 years, and the therapeutic treatment was starvation. You literally would starve the children for 3 years in an effort to just prolong their life a little bit. But the absolute end result was death. 1921 rolls around, they finally decide somehow, or were able to retrieve insulin from the pancreases of cows, and then therefore pork and beef insulins kind of evolved from that. Obviously we've come a long way from there, but I just think that's so interesting to know. I mean, that's not even 100 years ago, and how far we've come in such a short time frame. So with type 1, absolutely no insulin secretion or minimal. So if we removed the hormone from that patient, they would have nothing. It would just be a matter of time. They absolutely have to take hormone injections. There is no other way. There is no oral agent at this time. You cannot take insulin in an oral form because the bodies would break it down and utilize it. It's a protein, so it would not be able to be utilized in the body as the hormone that it needs to be. Type 2, a whole different animal. Very progressive disease, obviously the majority of the population. So the way that it starts is, if you've heard the term, is 2 things. One is insulin resistance, and then what I love to call pancreas poop out. That is not technical, but just a decrease in beta cell secretion of insulin is really the technical way to say it. But what happens is the body over time becomes resistant. It doesn't recognize it. So a good way to explain it is insulin is a key. It's a hormone, but it's a key that unlocks the door so that the food that you eat in the form of blood glucose or energy can be moved into the cells. So the way we love to explain it to patients is imagine that insulin's that key, and if you don't have keys present, that door stays shut, and if we're a cell of the body, we're starving, we're hungry, we need food, and all our food is out in the hallway. And we have no way to access that food. With type 2, what happens is that key, nobody recognizes anymore. It doesn't fit the lock. There's plenty of keys. We just it's not working, it's not functioning, it's not opening up that cell receptor site. So what happens is the body has to create and create and create more insulin. They're throwing more at itself, but it's just not being utilized properly. And that's insulin resistance. The body is resisting the insulin that you are making. Over time, what happens is you can only do that for so long. You got your little pancreas working at not 100%, but now 110. Has to work twice as hard to get the job done. And over time, that's going to fatigue the patient. And over time, those beta cells will begin to fail. Again, it's a very progressive, a long course. We don't know when that's going to happen. It's different for everybody. But the overall eventual thing is they can progress, and that's the difference between type 1 and type 2. With diet control, to oral agent control, to insulin control, they can go back and forth in all of those. They can reverse some of it, sort of. But overall, again, it's a very lengthy disease, a very progressive disease. So if we've seen somebody who's had that diagnosis for 20 years, probably their pancreas is not secreting at 100%, maybe 80%, maybe 40%. But again, the difference between a type 1 and type 2 is they still have some insulin secretion. So that's kind of the main rift between the two. A misconception is, well, can type 2, insulin is the differentiator. If you're on insulin, you're type 1, you're not type 2. Absolutely not. Type 2s can absolutely be on insulin, and it does not make them a type 1. Doesn't mean they'll ever go off it, doesn't mean they can't be on orals in addition to that, but it means that their medication will be all over the map at times. Gestational, something that was touched on as well. It just means, the way I think of these non-classifications, if you've noticed, gestational, or even the chemically induced, we call that, you ever hear of steroids? Steroids will increase the cortical response in the body, and it causes the liver and muscles to release extra stored blood sugar. So you have elevations in your blood sugar in a time that, yeah, it happens. In a fight or flight response, if you have adrenaline, that adrenaline is going to push out glucose into the bloodstream so the cells can utilize it to run away or bop somebody. That's kind of the body's natural response. So with that, I wanted to say one more thing before I said that. When we have those times, right, if you did not have diabetes, your body would be able to cope, it would secrete more insulin, and it would take care of itself. But now it's almost like this time of stress for your body, it doesn't work properly. Now we've introduced a variable. Here we're going to make you pregnant, or here you're taking a steroid, blood sugars go high. That's not normal, it shouldn't happen. Once the steroids go away, yes, the blood sugars come down, but do you understand there's an underlying issue? There's diabetes there, it's just not rearing its ugly head. And you can control it with diet, but you're a type 2 that is happening or on the brink of happening. Does that make sense? So during times of stress, you really see it rear its ugly head, like pregnancy, like steroid induced. So once gestational goes away, you're at a higher risk for type 2, but typically blood sugars will return back to normal, and you might not see evidence of that. Question?
All right, the chemically induced, like you said, with the steroids.
Yeah.
If you're on it for a long period of time and then you come off, can you get it back down to where it controls?
Yes. The answer is yes. Most of the time you can, because you've taken away that stressing agent, you've removed it, and the pancreas can keep up with the normal load.
If you have to stay on a low dose, will that make a difference too?
Again, it's depending on your body, and it can tax it more. If you think about it, whenever you're on a steroid, it's going to cause the pancreas to work a little bit harder. And in a time when you're not at a risk for it, sure, you could be fine. You can bop on a steroid, bop off, and your body will take care of it. But if you have an underlying predisposition to it with other risk factors present, it could induce those sugars to be high enough levels to either go into prediabetes or diabetes altogether. Does that make sense?
That's what happened to me. Yeah, because I was on such high doses of steroids.
Yeah. And it's tragic because nobody forewarns anyone, especially if you've already been diagnosed and they're somewhat controlled, all of a sudden steroid goes on.
Or not take it, and I chose.
You have to breathe. Well, breathing would be a good choice in that, but yeah, it does happen, and we see that even in diabetes, the benefit outweighs the blood sugar issue, and you have to do what it takes to breathe or to get the benefit of the steroids as well. And then surgically induced would be, for example, something called a Whipple's procedure, or something where they've had to remove a portion of the pancreas. Now they're not able to secrete insulin. and that would be surgically induced diabetes, where they become a type 1 because they have no capacity to make insulin at that time. LADA, have you heard of LADA before? Latent adult diabetes, latent autoimmune deficiency in adults. So it's a morphing of a type 2 to a type 1. And it's not something that's talked about very much, and it's very actually on the fence right now because they're thinking they don't present like a typical type 1. When you see a type 1 be newly diagnosed, they get very sick very fast. Blood sugars go up, they are in acidosis, they get very sick very quickly, there's nausea, there's vomiting. With type 2, it's very slow and gradual. You might not even know it, you might not even see it for years, but it's present, it's underlying. And think of the screening mechanism. We screen, but if we're only doing one blood test a year, you might have just had a good day where we don't see evidence of it. So the screening protocols are, they're okay. That would be a diagnosis of type 2. If there is, and the parameters that Nicole laid out for diagnosis, if they meet those parameters, the blood sugar parameters, that's diagnostic. You might have good days, blood sugars change constantly. So you can have good control with the disease still being present. So that's a good question because a lot of people will say, well, now that I'm on this pill, my blood sugars are totally normal, I test them, and there's no different. I'm just like my sister, brother, they don't have diabetes, our numbers are the same, we test on the same meter, whatever. The answer to that is this: take your pill away and look what happens. It's like blood pressure. Just because you take a pill, it doesn't mean you don't have high blood pressure anymore. Just because you take a pill, it doesn't mean that. Or if somebody is watching, they get diagnosed and they only have to control it by diet and exercise. That's a big one. Well, okay, so you say to yourself, well, if I just watch my diet, it's fine. That's great, but what's the difference? The difference is if I ate a piece of pie and that person ate a big piece of pie, and then we throw on some whipped cream and ice cream and everything else in the planet, you would probably see a postprandial or after meal spike from that with the person with diabetes, where you have the person without whose pancreas just whips that off, secretes the right amount of insulin, and you barely flinch from it.
Well, one of the factors is age. So
Correct.
I'm assuming that as people get older, they're more at risk for it, whether they're overweight or have high blood pressure or anything else.
Absolutely, just like everything else, your body changes with age, and so things that work to a certain way, we all know, don't work quite the same. It's just age. So it puts you at a higher risk, but again, it doesn't necessarily mean you will have the diagnosis either. If you have that family history, if you have the high BMI, if you're not exercising and doing all those things that are putting you at risk, age is going to be thrown in there, and that's something we cannot change. So you got to focus on the things you can. Even as we age, we should still, the more activity we can do, the more we can, lower our risk factors for that. But it's frustrating because a lot of people who are on diet, it's like the border. This is a good analogy that the nurse I started working with would always use. If we tell you, you remember the word borderline diabetes? You've got borderline, don't worry about it, just watch your diet. That's what we used to tell people. Well, if I'm on the border, I'm always going to put myself on the good side of the border. I'm not on the bad side. I'm on the good side. So if I have borderline diabetes, yeah, I should watch my diet, but this sleeve of Oreos when I'm watching LA Law, it looks really good right now. So it's just, I'm on the good side of the border today. But over here, no one else, no one lives on the bad, nobody wants to take that seriously. We're just told to watch our diet and exercise. Well, what does that mean? Being a dietitian, that's the thing that is, don't even get me started on that one. You're like, oh, I watch my diet. If I put them on a therapy diet, this is what I want you to follow. They'll come back, I did a really good job. Okay, what did you do? Well, I only cheated once. Well, what did you have? Well, I had some M&Ms, but just once. And in my dietitian mind, I go ×5, but okay. And then tell me what you ate the next day. We do food histories. Well, I had bacon, and then I had a sandwich for lunch, bacon and eggs. Okay, well, you knew bacon wasn't on your low salt, low cholesterol diet, but it was just once, Jenny. It was just once. That's all I did. Next day, okay, what did you have here? Well, we went to McDonald's, and I had a McDouble with a large fry. But it was just one time. I didn't do that every day, I just did it once. But everything adds up, and they're not thinking about all these little things that make a grand difference. So bringing it back home, again, just thinking about diabetes and its diagnosis, I think we did people a disservice in using the word borderline way back when, but pre-diabetes gives it some, oh, I better do something about that, versus you're okay, just watch your diet, you're on the border. I love that they give parameters for it.
What is your feeling about the over-the-counter A1C? tests that you can get in the drugstores now.
You know, I have to be honest with you, I haven't read a lot about that, and honestly, the patients I deal with, they really aren't utilizing that type of lab service. They're still encouraged to go through and get a plasma draw.
Right. But
So,
most insurance companies, you know, they'll only cover so much.
true,
Right.
true.
Unless you're already diagnosed.
But here's the other thing too, an
But if
A1C
you're
only
checking-
turns over once every 3 months.
Right.
Before you make a lifestyle change or a medication change, before you really see a result from it. So even if, you know, most insurances will recommend, like the ADA recommends quarterly assessments of that. Well,
Oh, okay.
quarterly assessments is accurate, and if the insurance lines up with that, then you can really see those changes. Are you improving? Are you declining? Are you stable? And what do we need to do to move you forward?
Okay.
Yeah. You know, I just haven't seen enough of them or really read up on them, to be honest with you, to give you a good solid
And I
answer.
keep seeing them in the drugstore and I can't find anybody who knows anything about them.
We like to pretend they don't exist. No, I'm kidding, I don't know. We don't encourage them. We still always utilize that A1C. And if they are following with an endocrinologist, that's going to be their method of care. They wouldn't rely on those over-the-counters. They wouldn't take those into their practice and say, okay, the over-the-counter stated. They would still make them go get a lab draw for that.
Right, but at least it would give you a sense of, okay, well, this is really something I need to be concerned about. Maybe I need to see the doctor now
That's true. That's
versus
true.
6 months down the road.
That could be if you're seeing the doctor maybe once or twice, you know, a year. Absolutely, that would probably be beneficial. I could see that. Again, the accuracy issue would be my only concern, but I'm sure that that would be easily researchable just to see how sound is that. Good question though. Anything? I love that. I would love Q&A the whole time, so we can just keep on that same theme. All right. Let's go ahead and move to complications because this was a part of the topic that I was asked to cover, and there's two types, of course, acute and chronic, that come alongside with diabetes. So the acute complications are hypoglycemia and hyperglycemia, high or low blood sugars. So with hypoglycemia, the American Diabetes Association defines this as glucose levels below 70 with symptoms. Symptoms include shaky, sweaty, dizzy, hungry, confused, just not thinking properly, not thinking clearly. If you've ever seen someone in a low blood sugar response, they almost appear a little drunk. They can't focus on you. They're not sure what you're saying. It's just because their brain is, you know, again, they don't have enough energy sources for the brain to do its job of reasoning. And so now they're kind of out of it. And they probably won't remember if they go into a lower environment. We teach the rule of 15, we meaning diabetes educators teach the rule of 15. And the rule of 15 means this: 15 grams of a simple form of a carbohydrate, could be 4 glucose tablets, that would equal 15 grams. It can be, if you've seen in the stores, these glucose shots, they're like 5-hour energies, but they're glucose shots. 15 grams of carb in a tiny, tiny bottle. 15 grams of carb. It can be a glucose gel, which is again in any pharmacy, but they look like a little tube of cake icing. You just squeeze that in their mouth. Half a cup of juice or 4 ounces, half a can of soda, and then they have to wait. You wait 15 minutes. And if you know somebody with diabetes, or if you yourself have it, the waiting is the hardest part, time petty. But the truth is that you've got to allow that sugar to get into the bloodstream to be utilized. So you have to wait, then you test again in 15 minutes, and if you're above that line of 70, now you can eat your next meal or snack, and you can dose insulin or take whatever meds or your protocol is for that. But the rule of 15, again, when you see lows, what we've traditionally taught, or what I've seen in the hospital system, is they go low and you do this. You eat everything in the refrigerator, and then you rebound up high with high blood sugars. It's not the way to treat it because it's this roller coaster that people cannot get off. And going low feels lousy. I understand the fear factor that they're going through. They're not getting their thoughts together. They know they're sick. It feels like a freight train is hitting them. Anything they can do to feel better, I get it. But the consequence of over-consuming is that rebound high that we're trying to prevent. So that's a kind of definition of hypoglycemia, or low. Hyperglycemia, high blood sugar, doesn't have a real number to it like a low does. You'll have symptomologies both in high and low ranges, different times. This is a gradual. Lows are fast, highs are slow. Extreme thirst, extreme urination, fatigue, hunger, blurred vision, poor wound healing, unexplained weight loss. You'll usually see these in clusters or groups, these symptoms. You wouldn't see one isolated. You wouldn't say, I have a headache, I must have diabetes. Or wait, I'm going to the bathroom a little more often, I must have diabetes. You probably see a couple of these symptoms together in combination with an elevated blood sugar, poor diagnosis protocols. So the treatment is increasing water, of course, whatever your physician recommends in this time if you've already been diagnosed, and you test the blood sugar more frequently. If left untreated, type 1 can lead to a condition called diabetic ketoacidosis, and type 2 can go into a different syndrome as well. Chronic complications, I will keep this very brief, but here's how I generally explain to patients. When you have been diagnosed and your blood sugars are running high, this puts you at an increased risk of the long-term complications. It doesn't happen in a day, does not happen in a week. This is months to years. And we know through certain studies that have been done that the higher the A1C is, the more out of control the blood sugars have been, the more glucose fluctuations, the higher your risk factor is for developing the long-term complications. So there's two pathways. There's actually more, but just to make it simple, there is the vascular system and the nervous system that are affected by high sugars. Both of these can be affected, and the complications that you see on the screen are a result of both of those, or one or the other. So retinopathy is obvious transitions of the eyes that can be affected by diabetes. Nephropathy is kidney disease. You're at an increased risk for kidney disease and therefore dialysis. Microvascular complications would be things like, oh, I reversed that, that's supposed to say macro. Macrovascular complications, large blood vessels, heart diseases, stroke, peripheral vascular disease, so circulation issues. And we don't know which comes first, chicken or the egg with these. I have to tell you, do high blood sugars cause this more often? We just know that people with diabetes have an increased incidence of this, but they can't really trace it very specifically back to why. You'll have a lot of theories on it. We just know that you are at an increased risk. There's a study, the UK PDS, which is groundbreaking for type 2s, and the DCCT, which is groundbreaking for type 1s, and showing and proving that improved glycemic control reduces the risk of these complications in diabetes. And then, as I mentioned, nerve damage, which is called neuropathy. Lots of fancy words I put up there for you, but basically your body nerves are affected by high sugars. They damage them, and in that damage we have all different types of systems in your body that are affected by nerve damage. One is hands and feet. Have you ever, again, seen anybody with diabetes, pins and needles tingling in their hands and feet? It can gradually lead to partial numbness and then eventually numbness altogether, where we would feel something like this, or we would feel a stove and go, oh, this is hot, I better remove my hand. And a person who has nerve damage in their hand would just go, hey, I don't feel a darn thing, it must be great, I don't know what's going on here. There was literally a patient, probably, I would say 7 years ago in Lee Memorial Systems, that was diagnosed with diabetes early 40s, nerve damage of the feet, was walking at a place called Sunsplash in hot summer Florida sun, which you all know is sometimes that pavement can get really hot. Walked all day long in bare feet, not thinking that it hurts because he has nerve damage of the feet. Literally, this is gross, burned the soles of his feet off. Literally, had gotten hospitalized right in our area. Who would have thought? But again, it's just a simple thing of I don't feel things. So if you step on, this is our analogy too up north, I have a Lego in my shoe and I jam my foot into that Lego and I'm walking around all day, we would feel that and go, ouch, this isn't comfortable, what's going on? Someone with nerve damage, no idea. They're just jammed in there with that Lego all day long. Pull the foot out and all of a sudden you've got a mass wound that's happened because you've been 8 hours in a shoe with a Lego. You see the point why this is so risky. So with nerve damage, it's very risky in diabetes. And just to give you an idea of how the nervous system, and there's many, many others, but the nervous system, a neurogenic bladder, aligns the bladder, right? So we have nerves that say, hey, we have to go potty. And if those nerves are damaged by diabetes, you'll never get the sensation you have to go. Bladder gets bigger, 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 bigger. You don't have the urge to go. Nobody goes to the bathroom. And then your incontinence will eventually happen because you lose the muscle sphincter and you just have no ability to know when you need to go and when you don't. So all of these things, which are very nasty and ugly, sometimes I'll use these with people and just say, scare tactic, a little negative reinforcement, just to say, you can prevent this. It's all in what you do now. Out of all the disease systems out there, and there are several, take cancer for example, you're diagnosed and you just are at the mercy of whatever how it works on you, that medication works. With this type of diagnosis, there's a lot of hope because you have a lot of power over it. You can do things to change the tone of your course. And so it's very important that you understand what can happen, but then it's also important to make that motivate you to do something different. So how do you manage yourself? Well, little pyramid here, but the base is always nutrition and exercise, always. So a lot of times I'll tell patients, listen, I don't care what medicine you take, I don't care how often you monitor, if your diet is all over the place, inconsistent, abnormal portions, I call it the accordion, like I go to Bob Evans and I eat bacon, eggs, hash browns, grapefruit, and a juice. And then I feel really guilty, so I just have a little cup of soup at lunch. And then at dinner time, I have my normal meatloaf, mashed potatoes, and green beans. And then TV time tonight, so I have popcorn, Doritos, and ice cream. So it's this huge, small, huge, small. No matter what medications you are on, it's not going to fix that. Your blood sugars, if your diet is all over the place, so will your blood sugars be. And so you have to kind of own that. That's the part of this you can control. Granted, it's not fun, but what I'll say to patients is you have to view your food differently. View it as medicine. Nobody wants to go, hey, I get to take a pill today or a shot. I'm so excited. But you have to look at your food and say, I may not feel like this, but I'm going to do it anyway because I know it's best. I know that by doing this, I can prevent complications. I can prevent the long term and the short term, and I'll feel better in the big picture. And I have a longer life with the best quality of life. So that's the way nutrition is. And again, a great job of giving just different resources to use. Because people are not cookie cutter. You can't all do the same thing. You got to do what works for you that makes sense and is healthy. On top of that, monitoring is so important. So when you're diagnosed, how do you manage? You test your blood sugar levels so you know if you're in the right parameters. And of course, medications as well. So medications, I told poor Nicole, I'm like, listen, I'm a talker. I could go an hour into all these medications because there's so many available right now for diabetes. But just so you know the different classifications, and please remember, type 1 can only be on insulins, type 2 can be on anything. And there are certain injectables now that are used for type 1 as well. We have all kinds of classifications of oral agents, and they work on different portions of the body. Diabetes is not just a disease of the pancreas, it's a multi-system disease. It's a disease that affects hormones, it's the hormonal system. It affects the pancreas, it affects the liver, it affects everything, and everything has a balance to it. So certain medicines will target specific organs. Insulins, there's about 5 different insulins on the market, including mixed insulins that can be used. Long-acting to short-acting to rapid-acting. There's just a plethora of weapons that can be used to control diabetes. And the newest on the market is the new injectable medications. And these are a classification of medications that they help the hormonal system work better. If you've heard of some of these Byettas or Victoza or Symlin, these are just different drugs that are injectables that help, again, with control, routing different organs of the body. So there's just a ton of different ones, but I just wanted to give you a brief overview. As far as monitoring, I do want to throw this out there. There are 2 resources that I've listed. One is the American Diabetes Association, and one is the American Association of Clinical Endocrinologists, or ACE. It shouldn't say AAD, it's ACE. But oftentimes we get asked the question, well, what should my blood sugars be once I've been diagnosed? And sometimes the doctor will give an answer, and that's fine. I used to be, when I first started practicing in diabetes, black and white. Has to be black and white. Well, the ADA says 70 to 100, you've got to be there in the morning. But then you start to understand that people are people. This is a gray area. Would I yell at anybody if they're 103 in a fasting range with diabetes? Oh no. It's a great number. So we have to kind of take the totality, but we have to have a guideline too. We have to have some kind of goal or target to shoot for. So with diabetes, ADA states fasting blood sugars, that means first thing in the morning before eating, 70 to 100. ACE guidelines state less than 110 milligrams per deciliter. Postprandial blood sugars, which means after eating, so less than 180 from ADA, 1 to 2 hours after eating, 1 to 2 hours post that first bite. And then the ACE guidelines state less than 140, 2 hours after eating. And if you work with people in diabetes, that's a tall order. It's a good target. It's a tall order, But we know if you can keep to those parameters, it will reduce the risk of chronic complications. So improvement, just kind of to wrap it all in a pretty little bow, this is taken directly from the AADE website. So this is the American Association of Diabetes Educators. They love to talk about the 7 self-care behaviors of diabetes management. So what can we do to improve once you've been diagnosed? What is your responsibility? What can you do? And these are great to empower people to do a better job taking care of their disease state. So healthy eating, the same things that Nicole mentioned in pre-diabetes are what we teach in post once they've been diagnosed with diabetes. The plate method is one. Carb counting is one. The exchange system, which is a little older, some people utilize in different forms. But it is about portion control. It is about consistency. I will say one thing about eating that we used to teach in the hospital, and that is survival skills. So if I walked into a patient's room, because when you're in the hospital, don't you just want the dietitian to come in and talk to you about what you should eat when you're sick? Of course not. Nobody wants to hear it. So what we do is I'm going to give you 3 points that I want you to work on. This will help your diabetes. 3 points, survival skills. Number 1 is do not skip meals. You just can't. Your body needs energy. It requires it. So the more consistent you are, the better and the more stable your blood sugars will be. Studies show when you skip lunch and breakfast that you will eat more at night. You know, whatever we do to say to ourselves, well, gosh, I haven't eaten all day, I deserve it, I'm tired, I've had a hard day, whatever self-talk you give yourself, it's very true, isn't it? If we sit and go, think about the days you have missed a lunch or missed a breakfast, and you finally sit down, we tend to eat more. So that makes a difference. Survival skill number 2 is portion control. If you overeat, you have diabetes, you will probably have a high blood sugar response, most likely. So portion control is very important for weight health and for blood sugar control. And then the third one is meal consistency and timing. Try to eat at the same times every day. It seems silly, but your body does so much better with routine. Think about that for a second. If you went to sleep every night at 10 o'clock, which probably some I would like to if we don't, but we'd like to go to sleep at a certain time and we wake at a certain time. Well, imagine it's New Year's Eve and you stay up all night. How do you feel the next day? Are you bubbling full of energy? No, you're going, oh my gosh, I just got to make it through the day. I'm so tired. How am I going to make it? Your body, and think about when you give it food. So I'm going to say, hey, Nicole, it's time to eat. Oh, just kidding. You're not going to eat for a couple more hours. You know, we're giving our body food and we're taking it away, and your body gets used to expecting when we fuel ourselves. It's like, hey, I need gas at breakfast, lunch, and dinner, and a snack. Well, when you take that away and when you make it inconsistent, your body is affected by that. Just like it's affected by poor sleep habits, it's affected by poor meal habits too, and timing is one of them. So of course, being active, of course, monitoring your blood sugars, taking your medication appropriately and on time, problem solving. And that means, I thought that was funny when I first saw that, and I go, problem solving, but keeping that person sharp, right? That person has to know, this is a gray area. They've got to know how to Sherlock Holmes their own disease. Gosh, I'm going low all the time, maybe I need a medicine adjustment, I better call my doctor. Or boy, I'm running high, am I doing something to contribute? Maybe I'm eating too much. Maybe I'm missing doses that I was supposed to take and I wasn't. So making sure that they understand that that is, they own it, their job to problem solve it. Reducing risks, I thought this was good because this empowers the patient. What can I do? Smoking cessation, again, that always helps. Regular eye exams to catch any chronic issues early, as well as regular foot exams, as well as dental exams, because diabetes can affect the oral health as well. Blood pressure monitoring, monitoring their blood sugars appropriately, and maintaining records. And then, of course, healthy coping. You know that diabetes is a disease where dire depression goes hand in hand with it. I mean, think about it. Anytime you have a chronic disease, that's something that you have to deal with psychologically. So knowing how to reduce stress, knowing when and how to get help. But I thought those were very interesting and helpful. But their website does a really good job with free handouts on any of those topics. So again, really, really good. So I know I'm so windy, but I'm so happy to answer any questions if you have any. Or other campuses. Hello, other campuses.
I just have one curiosity. I don't know if you run through this, the seminars that you give, but like, going by this, it shows that men are more at risk with diabetes than women, but yet in this room there's only 3 guys.
Yeah, I can't answer that part, why there's only 3 guys here. I don't know. But can I just, is this terrible if I say this? Would
Yes.
this be horrible? I mean, I've been around the block, I'm 46, but I will say this, because I am married. It seems to me that women, because we have children, maybe we're a little more nurturing and caregiver-ish because that's the nature of a woman. I think men, they get busy, and sometimes they don't always put their health on the forefront. Is that gentle enough? They kind of maybe take themselves for granted a little bit. I'm trying to be soft about it, but you know, again, I think that's an excellent observation that needs to be taken more seriously. My concern is that men aren't taking their health more seriously. When I do work with couples, because I have a lot of the older population, oftentimes it is the woman managing the man. And again, that is my experience and my observation. That is no way, shape, or form true to society. Just sharing with you what I see. But I have to take that woman and grab her little face and say, this is his disease. I know you want to help, but you have to let him fall. It's like a child. You got to let him fall on his face at times so he understands that if you were ever to go anywhere, God forbid, they've got to manage it on their own. I mean, they're going to be left going, I don't know how to use a glucose meter, or how do I draw up insulin? I mean, they have to know how to do that simple stuff, even more so with pump therapy. So, good observation though.
Okay, okay.
All right. Well, I'll be hanging around, so if you guys have anything specific, I'm happy to help.